think I have a mic on that works. Very nice to be with you today, and nice to be joined by folks online. Dwayne, I am feeling a little left out. I would have rather been invited to your session in Kenya last year. So maybe we can do this again sometime. So I have a confession to make. I know she was. In fact, my wife is also in the back of the auditorium here. She's going to keep me honest here today. I have a confession to make. I absolutely love data. Now, I love Ann, I love you more than I love data. But in fact, I have loved data longer.
What about data on your wife?
Well, that would be true too. So, data is really fascinating in healthcare for all kinds of reasons. I mean, it helps us do things that we could not do any other way. It helps us learn. It helps us correct our misconceptions. And we've also in healthcare been fascinated by the time it takes data to get from the bench to the bed, or the knowledge due gap, we call it in healthcare. And in general, most people estimate that's like 10 years from where we learn it and where we actually do it. And that struck me for the first time. I'll pause for this story. For the first time, sitting beside a patient in a hospital in Chicago during my residency training and interviewing this patient. And as it turned out, her kind of life history, as the way it started, was identical, as far as I could tell, to mine. She had an identical twin. I have an identical twin. We were born 2 months premature in the mid-50s, within just a few days of each other. Not my brother and I, this woman, okay? And they were 2 months premature, born to a preeclamptic mother. I was breech. I think this woman was breech. We had respiratory distress, near SIDS, returned to the hospital for respiratory distress. I would have been normal had it not been for that birth experience. But what she didn't have that we had, something very specific, her physicians in this Chicago hospital had not read the literature and done something with the literature where it talked about oxygen-harming premature baby eyes, something called retrolental fibroplasia. And she and her twin sister, in this very prominent Chicago hospital, the two of them were forever blind. And in my community hospital, right here, St. Joe, Michigan, my community hospital, the clinicians had seen the data and done something with it. And it really impressed me. Bigger's not better, better's better. What you have to be committed to is follow the data and do something meaningful with it. And for this poor twin sister, her life turned out dramatically different because her physicians failed her. And that really set me on a course to say, this data really matters, and we want to understand it. And in fact, we want to do something very meaningful with it. On the other hand, you see things like this. This was published by John Ioannidis. He kind of made a name for himself saying most of what we read in medicine is wrong. That there's all kinds of bias in it. Now here's one of his conclusions. For many current scientific fields, claimed research findings may often be simply a very accurate and maybe statistically significant measure of the prevailing bias. And they unpack that in all kinds of ways. And I don't believe his numbers. I don't believe quite his calculations. But over my clinical days and my leadership days, this is true more often than we wished it were. And there's all kinds of reasons for that. So I love data, but I'm also, I think, a self-proclaimed, data skeptic. I've got to go back here a few slides. There we go. So here's another famous quote that I love Daniel Kahneman. Daniel Kahneman was a psychologist, passed away about 2 months ago in New York. Psychologists that come in a Nobel Peace Prize in economics is a special kind of mind. And he is famous for cognitive biases, and that applies all kinds of ways to data and research. He also is the father of behavioral economics, He spent a lot of time on the economics of happiness, and I think as Christians we should care a lot about that. Prospective theory, loss aversion, some other topics. But here's one of the things he said: it doesn't take many observations to think you've spotted a trend. And most of the time it's not a trend at all. And in healthcare we are always, at least 3 data points, 4 data points. We want run charts, we want to spot trends, we want to predict the future with those trends. And I'll show you some of that as we go along today. But I keep his wisdom and his guidance in mind as we talk about data. So I'm going to start with the answer to the title of my presentation, The Data I Need. Just make sure that we're real clear that this is the list. This is what I've kind of described as perfect data. Why wouldn't we want data we can trust? Data that matters, data that's fair, data that we can do something with, data where there's a return on that investment, where it gives some value back to society, data that is easy for folks to access. Reproducibility is a huge part of studies. There are many commentaries about medical research that says less than half of many studies that we see as in the literature as something meaningful can be reproduced, even by their own researchers. Now, I'm not sure that that would be true in the data that you're looking at, but there's reasons for that, and there's folks that make that claim. We want data that makes a difference in society in some way, that matters. I want data that is trendable, over time, and data that we can benchmark, and you'll see some of that as we go. In healthcare, data is utterly pervasive, and I'll share some examples that make that so. This is adapted from a gentleman called Dennison, who published this in 2011, that looked at the doubling time of knowledge in healthcare. So I was born about when this graph started, and at that point in time, it took 50 years to double healthcare data. When I went to medical school, that's the next data point, his data point on here, actually graduated from medical school. 50 years was now 7.5 years. And as I took a leadership position, which is about the time this was dated, the next bullet point, that was 7.5 years. Now the projection there was that data would in healthcare, that the doubling time would shorten to less than a year by the time we're in the mid-2000s. Now others would say, no, that's still around 5 years. And then COVID came along and, of course, produced a pretty big bump in shortening time on healthcare data. However you interpret this data, it's becoming harder and harder to keep up. When I was a family physician, I looked at what I needed to read every day to keep up, and did some calculations on the sources of data that I want to look at, the articles I want to read, and I came to this stark conclusion that if I were to read 2 relevant articles in my field every day, as a young physician, in 1 year, I would be 100 years behind. Now, what are you going to do with that? So, I made a deliberate strategy. Here's how I'm going to think about data. Here's how I'm going to read articles. And I very quickly learned, here's how I can say, that's junk and discard it. That's probably worthless. I'm not going to spend any time. Or that's gold. I'm going to really pay a lot of attention. I'm going to let that change my practice. And it was years later that I married Ann that she said, by the way, confirmational bias probably came into play there, and so very likely what I did for years to keep up was not effective. Thank you for that conclusion, Ann. But in fact, we all are subject to what we read, what we remember, what we pay attention to, what we care about. And confirmational bias is alive and well, clearly in healthcare. So at Coral Health, I talked about a lot of data. We have 40 petabytes of data stored. Now, if you know much about a petabyte, that is 1,000 terabytes, or a quadrillion bytes. If we were to put those on sheets of paper as text, that stack of papers would be 2 million miles high. Now, I just did something obvious to all of you. That was a gross misuse of data. That's the way that, thank you for agreeing, a gross misuse. I mean, bytes are not the same as text on pages. The thickness of paper is totally irrelevant to how much storage there are. But you see how quickly we can go into something that's just utterly a meaningless comparison. But in fact, if you took those 40 petabytes and you made a high definition of a movie, it would play for more than 500 years. That's real data. Probably a more accurate way to describe a petabyte. So in the middle of the early, the last few years, we have had the data event of our lifetimes. Would everybody agree to that? Nothing has contributed more data fields to any discipline anywhere, I think, than what COVID has done to biomedical research and to healthcare. So I think you all have seen what is the Johns Hopkins Coronavirus Resource Center map. Have everybody seen that? About everybody seen it? All kinds of others have copied this and done other things related to it. But this created, I believe, data voyeurs out of us all. I mean, I could hardly get up in the morning and say, what's happened to COVID? Across the world, across my country, across my state. This was in late 2020. And you can see at this point, there are 35 million cases global. And when you get down to 423, it makes that data pretty believable because it is that precise and accurate. And it's being updated just continuously. And of course, they tracked global deaths and many other aspects of the coronavirus activity. Well, when they look back, World Health Organization looked back at this time period, that number was probably not 35,000, or 35 million, it's probably 60 million. Probably at least twice that much. At the end of the year, probably 85 or 90 million something cases. And at this point, we were also claiming that the case fatality rate was about 3.6% across the globe. Now, of course, case fatality. Is the numerator right? How would we know? Well, maybe. Is that death from COVID? Is it with COVID? Was it recorded? Was it reported? Are folks getting buried out there that aren't? We knew in China the number of deaths that they were reporting was dramatically different than the number of urns they had set to cremate and bury people in, by a factor of at least 10. That is pretty well been reported. Was the denominator right? Making a diagnosis of COVID depends on the test and actually confirming the diagnosis. So, there's great accuracy in this, but probably also there's a lot of inaccuracy as well. We, of course, watched COVID across Michigan. This little snippet of the prevalence of COVID in Michigan was in mid-2020. And you'll notice that the total cases are about 2,000 at the peak. And this made us nervous as we looked down the road. And in fact, as we got our peak, it wasn't 2,000 a day. It was 10,000 a day, 5 times this amount. And across the world at that time, it was about 1 million cases a day. But we watched this carefully and tried to do something meaningful with the data. We also had our own county dashboard. We had dashboards running out our ears. If you are familiar with how we tracked COVID, we knew how many cases we had every day. We know how many people had tested positive. We know how many people were tested. We know how many people were in the hospital, how many recovered, how many on ventilators, how many had died. And we knew the prevalence across various regions, and where we were getting more COVID and less COVID. We were tracking them in nursing homes, other places. So we paid a lot of attention to what was happening, and there was a reason for that. We'll get to that. We also compared our experience, and I think everybody did. How do we compare with other counties, with the state of Michigan, with the country, with the world? And you can see here was our little county data. We had 153,000 folks. At that point, we had about 2,000 COVID cases. Our positive prevalence within the county was 1 in 75 people. And we had, at that point, a case fatality rate of about 3.6%, which ran behind Michigan. We felt good, a little bit behind the U.S. and a bit ahead of the world data. Here's another quote from one of my favorite authors, Daniel Kahneman. Our comforting conviction that the world makes sense is on a very secure foundation, our almost unlimited ability to ignore ignorance. I think that's a really profound statement, and I can tell you in healthcare, we felt ignorant. So many things about COVID just rocked our boats in ways that we had not predicted. We had never seen a virus that did this much damage to this many parts of a human body in this kind of an unpredictable way, where folks of the same age, living in the same home, you had one die brutally and 1 remained asymptomatic. We had no kind of mental models to understand that. The literature just exploded with research. Within the first year and a half or two, we got somewhere over 200,000 scientific articles published on this. We had teams, Corewell Health, we had teams of young physicians assigned full-time to watch the literature and try to abstract the lessons that we need to learn, because we had people dying in ICU beds next door. We never had that kind of urgency to try to close that bench to bedside or that no to do gap. And in the middle of that chaos, things became very, very personal. So meet my brother, my twin brother. I referenced him earlier. This is Dr. Lowell Hamel. This is a photograph taken April 11, 2020. Now, you can't see it, but he and I are on the phone. You can see I'm FaceTiming him. And what he's looking at is his positive COVID test and describing how he feels. And, yeah, it's positive. And so he was, at this point, leading our incident command related to COVID in our health system. So every day, he's with a team of folks looking at data, trying to save lives, trying to make sure we have enough of everything. He's leading those efforts from our command center. And he's saying, well, I guess I'm going to have to do this remote today because I really shouldn't come in, although I feel pretty good. I shouldn't come in. So forward about 3 or 4 days, he's getting short of breath. And it's time to admit him to the hospital, which we did. And here's 10 days later, he's real short of breath. This is in our St. Joe facility. You can see he's not paying much attention to the camera. He's hypoxic. He's not feeling good. And we're making a decision, are we going to intubate Lowell? At that point in time, we were thinking that convalescent plasma really made a difference. This is the plasma of people who had the disease, and we were hoping we could harvest some antibodies and give it to folks and help save their lives. There's a lot of excitement around that. We spent more time and energy across the state of Michigan trying to do that, and it was complicated because you had to match, of course, the blood type of the plasma with the blood type of the person who was sick, and then you got to decide who got it. And at that point in time, what we're giving, which is totally irrational, we're giving to the people that were almost dead. You know, when does it make sense to give a novel treatment? I mean, you understand the ethics of it. Well, we're not going to hurt them. They're going to die anyway. But you're also not very likely to help them when they're almost dead and you're giving passive antibodies. But we were looking for those. We had none available in St. Joe. We had a few that were coming from across the state of Michigan. We sent Lowell up to Grand Rapids to be admitted to the ICU there in hopes. And then we have people around the world praying that he's going to get a dose of convalescent serum. And here it is on April 11. Fast forward 2 days. You can see he's now got an NG tube. He now has a trach. The convalescent plasma was finally given and didn't appear to do anything. We watched as numbers looking at functions of the brain, the heart, the liver, the kidneys, the pancreas, clotting mechanisms, inflammatory markers, where every one of those headed south for about a week in a row. Now, as a doc, I can extrapolate the future from data like that. And a Friday night, I had been watching these trends. And a Friday night, I wrote his death notice because tomorrow it was going to occur as I watched these. And had folks praying around the world. And if you lost somebody from COVID, I would just stop and say, I don't understand all the reasons that some prayers are answered in ways that we really want, and some prayers are answered in different ways. But literally folks praying from around the world. That Friday night, one of my vice president reports at Lakeland Hospital was awakened in the middle of the night, impressed that he and his family should pray for Lowell. I didn't call him. Somebody else knocked on his door and said, hey, Lowell needs your prayers. Lonnie Ali, the wife of the late Muhammad Ali, friends of the family, down south called and said she was impressed to pray, and actually awakened some Muslim friends to help pray with her. I've heard that story now other times, not just other times, where folks are really impressed to pray. Sabbath morning came along, and we chatted with the doc, and every number was starting to head in the right direction, not the wrong direction. I mean, this looks like a miracle. When we, I chatted with Lowell as we were thinking about intubating. At that point, 75% of the people that got intubated never awakened. We literally got this picture in the ICU because we set up remote video channels so families could watch their loved ones die alone, because of course we couldn't let folks in the room. So this was Sabbath morning that we got this shot, and he started, I said, he's going to recover. A day later, the doctors are talking about 2 weeks of rehab in our rehab hospital. I said, I don't think you understand. He's going to be home in 2 or 3 days. And in fact, there he is. It's pretty amazing when you can use data to help save lives. It's also pretty amazing when you feel you just don't have the data you need. And in this case, we just didn't have the data that we needed. But 4 days later, he was walking in the woods, obviously weakened dramatically, but has recovered. About 3 weeks later, he came to my house and said, look here. And he kind of turned his neck. And I can spot from a distance a 4 or 5 centimeter mass under his mandible on the right. You've got lymphoma. He said, yeah, I know that. Just don't know what type. And he went through a cancer battle and has recovered nicely from radiation and from chemotherapy. Likely the reason he got so sick, we just didn't know it then. And possibly the cancer was stimulated by that virus as well. But that's why data matters, to help solve problems like this. So at our hospital, we used the Penn model to try to predict everything we possibly could about COVID. And this was a really rare disease, really unusual disease for us. We had never applied the Penn model to something like this. So the Penn model says, given all kinds of things, social distancing, how infective an agent is, something related to what we call R0, how long people in the hospital, how many people in ICU, ventilators, all those are part of the assumptions. What's going to happen in your population? What's going to happen to your capacity to care for that population? So consider the comparison. If an average flu person in the average flu season infects somebody and nothing gets in the way, we don't have medication to treat, over the course of 2 months, that one person is going to infect about 380 people. What we were seeing with COVID is that one person over 2 months could infect up to 99,000. I mean, if nothing got in the way, if there's no social distancing, you just let normal. I mean, that was the data that we were using. And we were, of course, communicating with caregivers in China, and then shortly after that with caregivers in Italy, trying to say, what on earth is happening? What are you seeing? And it was terrifying, I can tell you from the healthcare point of view. Terrifying, because literally there were doctors and nurses dropping from the disease as they were trying to save lives. The number of patients markedly exceeded the capacity to care for them. It was brutal. And across the U.S., we're saying, how do we prevent that outcome here, if possible? We also looked across the country at any county about our size, with our population density, with our distribution of health care, and tracked what was happening to them so we could help refine our models. We looked at counties across Michigan and where things started and what happened in terms of the growth and what happened in those facilities, and used them to help inform our models. We also looked at the difference between urban and rural in Michigan and the time course of the disease transmission in those areas. You can see on here, this is where we started with Berrien and Kent County, which were kind of the center pieces of the south and west region of, at that point, Spectrum Health, now Corewell Health. And we did things, by the way, at that point, your relative risk to get COVID when you were in an urban location was 10 times. Now, of course, that changes over time. We knew it would change over time, but at that point, 10 times more likely if you're in an urban area. And then we looked at, so what's happening with the prevalence of the disease within various age bands, what's happening in the mortality rate. I put this together from, I guess, 3 different sources, and this will change over time. But just take a look at this graph if you love data. This graph has to interest you. What do you see from this? So the orange line is the distribution of population, by decade. The blue is across, and this was mostly China data, is how likely was somebody to get infected in those various age categories, and the red line is expected death. So taking a look at this, so who was markedly less likely to get sick? The young ones. And almost none of them died. We saw deaths in Cornwall Health at every decade band that's represented here, but markedly less, and almost all with some significant immune issue. Almost never with just a normal healthy person. So where is that risk, kind of the representation within the population and the chance of getting COVID? Where is it about a balanced bet? Where is it about even odds? Between 30 and 40, right? That's where those things kind of line up. And of course, where are you just markedly more likely to get sick and markedly more likely to die? That's the 80-year-olds. So we figured this out pretty fast in healthcare. And I'll share some more data on who's more likely to get sick, but this was fascinating. Our effort was mostly to save lives between 40 and 100. That's where most of the mortality, most of our hospitalizations, most of our ventilator use and death was over 40, although we saw some younger folks. We also made dashboards on everything that you can imagine. How many tests we're doing in the county, how many of those turned positive, how that trended over time, what happened with holidays and weekends, how we could prepare for the upticks in COVID cases when folks were brought together, where folks were in our facilities, how we managed that. We, in fact, had what we call hot zone bosses. They would stand there and watch people wash their hands, put on gowns, put on face masks, take them off, make sure they did it perfectly, and just train and train and train to make the risk of going in the room almost zero. Losing caregivers to COVID, or even having them get sick with COVID, would be a huge hit on our capacity to take care of our friends and neighbors. We had to keep them as well as we could. We also got down to tracking individual patients. What was their experience in healthcare? What resources did they use? How long did they stay? And ultimately the discharge or disposition of those patients and where that was occurring in our county. We also used the data, and this is going back to the Penn predictive model. We use our data to say, with the current assumptions, at the current rate of growth in these various areas, when are we going to run out of ICU beds? Now, when we started this April 1, if we had done nothing, and if this had followed the Penn assumptions, which is not necessarily the case, so they're big assumptions, we predicted we'd run out of ICU beds, before we got to June. We'd run out of ventilators in late June, and we'd run out of total beds. If, in fact, the social distancing at 30% were the case, we anticipated we would have way more sick patients than we had beds. The reason across this country folks spent so much time with hand hygiene, social distance, and masks were mostly to make sure that we didn't run out of capacity to care for friends and neighbors. And I think that it mostly helped. Not nearly as well as people, of course, claimed, and much better than others claimed, but I think it was helpful. We also tracked our supplies, our inventory of everything that mattered. This is a picture of our sanitizers. We did modeling and burn rates on everything that matters, say when will we run out and what do we need to do differently to care for patients. We also spent a lot of time tracking the staff. Are we screening every day for symptoms? Are we testing frequently? Are we sending them home appropriately if we think they've been exposed or we think or if they have COVID? And this was one of the dashboards to help track that. It also elucidated a number of things that we knew we needed to do that we weren't there yet. And one of the things very interesting about data, when you look at it carefully, you always learn something, and that it also helps highlight all the things you don't know and what you might do and how you can close that gap. And these were things that we planned to, and ultimately did. How do we get better prepared for surges? What are we doing with staffing and cross-training of those staff when we run out of staff? Are we thinking through temporary housing? If we exposed a nurse to COVID, we had plans and did send that nurse to a hotel instead of home, so as not to expose her whole family. Particularly that was concerning when folks had older people, more vulnerable people staying in their home, and we felt responsible. If we've exposed you to COVID, we don't want to be responsible for giving COVID to the rest of your family. We did a lot of work around advanced directives. What do you do when an 86-year-old in a nursing home gets COVID? Do they want, do they get, do they need all the same treatments? As we collected, by the way, that data in nursing homes, a quick aside, it was just amazing when COVID, and we knew COVID was going to enter nursing homes and hit us early. And when we watched that data, about a third who tested positive never got sick at all. About a third got sick, but it didn't act much more than a cold or the flu. And about a third just went up and died. And looking at, and this was true with others around the country, it was hard to predict. And we couldn't do it very well. So what's different about the third that die and the third that are sitting up having their lunch and saying, what are you worried about? I feel fine. And we saw them in that full spread in nursing homes. So roll forward a year. This was the picture in 2021. We now have vaccines. And we distribute across the globe 13 billion vaccines. We have never had a vaccination frenzy like precipitated by COVID. And this is kind of the uptick by age category of vaccinations in 2021 in the U.S. And you can see we pretty much went, very rapidly from about nothing to up in the 80, 85, 90% range, which was a pretty dramatic. That, by the way, doesn't occur in any country unless you literally are marketing and selling vaccines. And a lot of that occurred, is really pushing this support. We gave across Corewell Health, administered during this period of time, about 500,000 doses. And by the way, it didn't kill anybody. We had four or five hospitalizations for serious, allergic reactions, which you would expect from the numbers. That's going to occur. But we were pretty careful. A lot of folks are talking about folks dying, and there are absolutely where that has occurred. But that didn't occur, at least with us. I love this graph. Here's another one. You just have to kind of sit and say, oh, that is really insightful. So notice this is cases per million on a logarithmic scale. And so, it is compressed intentionally. And you can see the dotted lines are age, decade bands or so for folks that are unvaccinated, and the solid lines are those that are vaccinated. So what do you see in this? I'm just interested. Call out something. What do you see? I'll repeat it so the folks online can see this.
Vaccinations effective.
It helps. Vaccines help. I mean, how can you not say that vaccines they help? No question about this. So what do you suppose is going on here with this bump in cases per million about in the middle of that graph? So as that turns out, that's Delta, the Delta strain. I mean, just as obvious as be. We got something just happened here. We have a special cause variation of some kind, and something happened. Now, look at the graph closely. What do you see in the relationship between the vaccinated and the unvaccinated in the face of Delta? It's right there in the slide, obvious as can be. I mean, it's like reading an X-ray and saying there's a fracture. This is not ambiguous. So, so you can see that the case rate went up in both. Oh, wait a second. I thought vaccinations were supposed to prevent disease. Isn't that what we all claimed earlier? Take this vaccination, you won't get this disease. Well, it's pretty easy to see from this, we might have to revise that story. In fact, folks who are vaccinated did get the disease. Now, something that's a little more subtle, but just about as obvious is that X-ray has a fracture. When you look at which ones of those increased more, vaccinated or unvaccinated, within that Delta strain, who, relative to their baseline, got more COVID? It was the vaccination. And in fact, as you look back at this, somebody who, in the Delta strain, we had about a 10-fold increase in COVID cases of people that were unvaccinated, and we have a 14 or 15-fold increase in those that were vaccinated. And so that's why, when the popular press took this, they just went wild with this. Oh, it's a much higher risk when you're vaccinated. Well, it is true, relative to baseline, the increase was definitely greater. And that is a fact you can see from this data. Obviously, any clinician would say is, okay, they got COVID. How sick were they? Did they go to the hospital? Did we put them on ventilators? Did they die? And of course, none of that is true. They didn't. So it was very protective, but it wasn't protective against what we claimed earlier, says you won't get the disease. In fact, that turned out not to be true. One of the things we have to be very careful in healthcare is overclaim on our data. And in fact, there was a lot of overclaiming on the data. Here's another slide. This is related to the case. Oh, I should just say one more thing on this one. On the folks that are vaccinated, who got the least benefit from being vaccinated? The 50 to 64-year-olds, the folks that are 65 to 80, the folks that are 80. Who got the least benefit from vaccination? Who's lowest on that list there? It's the oldest. And you would hope the oldest to get the most benefit. In fact, when you're vaccinated, they got the least benefit. And we went back and looked at why is that so? Well, the vaccine is not as immunogenic in people that are older. It doesn't give you as much benefit as you otherwise would expect. I'm going to have to move here. So here's another one I just love. This was looking at the state-level COVID trends by region. And this one, you just look at this graph and say, what does this tell me? So in April, who had the worst COVID trend? The other one, Northeast of the United States? Okay, forward to July, who had the lowest? Who was the best? Same one. Okay, let's go back and look at April. Who was in the best shape? South Central. Take a look in August. Who's by far the worst? So what do you suppose the people in the Southeast, the red, were doing in April? They were bragging. We're geniuses. What we're doing works. You should emulate us. I'm sorry all you guys are suffering, but we're doing the right thing. I mean, the bragging was just insane. And then, of course, when you come to July, who's doing the bragging? And we saw that in the literature. It was just phenomenal how people would misuse data. And we looked at it and said, I'm sorry, we're all going to pay the price. It's going to come now, it's going to come later. And hopefully, if the vaccine works, that's helpful. Hopefully, if we have treatment, that's going to be helpful. But when you see these trends, it was pretty obvious that we all didn't get sick at the same time. Here's another, I think, a really interesting. There was a review of COVID cases, of mask use, personally reported mask use by the New York Times. In every state, they did a sample. And they said, so how often are you using masks? All the time? Never? And they just did that across the U.S. And somebody said, well, that's really interesting. I'm going to go back and correlate that with what's happening with COVID at those same times. And they kind of scored the mask use, and then they said how much COVID, and in fact then plotted that out. And what do you see here? This was the best evidence that nobody saw, because this was done later, that in fact masks worked. Most of the data we had with masks was just junk data. Very small, observational, not controlled. The best controlled study came out of, I think, Pakistan, where they had some of having two cohorts, masking and not masking, and compared the experience. But this was the best evidence that, in fact, mask use. In fact, a 10% increase in masks with a 30% decrease in COVID cases. And I think that's a pretty significant data. This is one of the most beautiful data slides I've ever seen in my life. This is just amazing. On the top is how many people are dying from COVID over time by region. On the bottom is what proportion in those regions of the total. And you can see early on, the U.S., that's the blue, the EU, and the EU and the U.K., the blue at the top, and gray, the U.S. They paid a heavy price first, then we paid a price, then things got better for Europe and America, and it got worse, as you can see, through most of South America and India. And then you can see this huge uptick in the late winter in 21 and early 22 that just was brutal, where we had daily deaths over nearly 9,000. But what a way to present data. And there's all kinds of very interesting lessons in that data. So we're going to move to another topic here. So what are we looking at? This is the incidence per 100,000 of a disease. I'm not going to tell you the disease right. And you can see that this is global. It's worse someplace than others. That's pretty clear. There's a large variation. I mean, you go from an incidence of about 1 in 3 individuals to on the frequent side, on the infrequent side, to 1 in 1,000. Huge variation across the globe. Obviously, something it matters. Somebody's taking a look across the world, and in fact, this is also associated with deaths, and here's the proportion of the deaths from that region that are related to this disease. And you can see that as everywhere from less than 8% to up to 65% of the local deaths. Huge variation in what proportion of deaths occur because of this disease. You can also see it's more likely in older people. That's the blue line at the top. You can see it's more likely in males at every age, more likely to be fatal in males than females. And here's the race. You can see it's more likely, this data, more likely to kill a black, less likely to kill a Hispanic, and least likely to kill an Asian. And Caucasians are in the middle. And that also, you see it's an incredibly symmetrical distribution there between these age groups of that mortality rate. And even across the U.S., there was literally a threefold difference in this disease, a threefold difference in mortality rate from state. What is causing all that disease? What's causing all that death? What's causing all that variability that we haven't heard about? And mostly, we hadn't heard about. This is a global crisis, affects 50 million people a year. 11 million die, about 20% of the mortality across the globe, and survivors don't always do perfectly well. Well, let me give you one more clue and then see if you can guess who this is. Do you know these people? Yeah, so Muhammad Ali on the left and Christopher Reeves, who played Superman in the Hollywood movies, on the right, they both died of this disease. Muhammad Ali was 74, Christopher Reeves 52. So what is this? Any guesses? So this is sepsis. And the World Health Organization hasn't even ranked it for years. You know, cancer and tuberculosis and malaria and all kinds of other serious, but the notion of just sepsis as a diagnosis is really relatively new to the list of what is most likely to kill us. And in fact, we've had 30,000 articles in the last 10 years on sepsis. This is a really important topic. It is one of the most fatal things that you can get, that you can be well today and dead in 2 or 3 days. And we have seen that in this community. It just happened to my neighbor. Actually, was my neighbor, is now on the West Coast. This week, died from sepsis. And we have some experience in our healthcare on sepsis. This is our mortality rate for sepsis tracked over a period of years. And you can see the green line is top decile performance. So that is you're up in the best in terms of mortality rate in the country. And that's where we were in 2011. And you can see, things got worse for a while. You know, that mortality rate went up. Now, still was better than average, but it wasn't in the top decile. Then we did something. We put on our electronic health record. We built in that record all kinds of things to help us track and diagnose and treat effectively with care protocol sepsis. And you notice immediately dropped below the best decile in the country and started saving lives. So the little period here that you see on this graph, as compared to average around the country, we were able to save 32 lives. 32 people had birthdays and Christmases because of this work by that one inflection point of paying attention to the data. Now, it is really complicated to do that, and I could describe, it would take hours, how we think about that, how we bring the data, what we decide to do, how we decide to measure it. But if you're deliberate about taking the data and doing something with it, you can make a big difference. Some significant challenges with data in healthcare. You have seen this everywhere you go, but these are ones that we live. It is hard to get high-quality data. It's hard to get high-quality data from multiple sites. We have all kinds of constraints related to privacy and security that we care about. There's ethics involved in what you study, what you don't, what you do with the data, how you look at it. In healthcare, we have all the time people that aren't data literate, smart people that just have not spent time immersed in data and figuring out what you do with it and how. And then, of course, the data integrity, that we know it's valid, we know it's reproducible, we know that we've looked at it, made decisions appropriately. That is summarized on this slide on kind of the complexity of thinking about data in healthcare. We also have a myriad of sources. You know, I talked about all the data, the 40 petabytes of data, but that comes from all kinds of different sources. Some of them in healthcare are listed here and their significance. I won't spend much time reading that to you. This was our best guess at our data position in 2021 when we decided to do something about it. These are actual sites that provided data and actual connections to those data sources and the way we sorted and understood data. And you can see that this is rather chaotic. And we said, we can't live with this. We want to do something different. And spent a fair amount of money and resources simplifying that. We're going to keep one copy of everything, run it through a data lake and a data warehouse, and make that more accessible to our users and our researchers, and eliminate some things that added complexity. So this is also the actual picture of what is being built, and we're mostly there. So here's one of my favorite studies. About 10 studies, I love to tell you our favorite studies, but here's one of them. And I like a study that just changes my mind, that proves me wrong. You know, I was impressed early on how many things I didn't know. And we talked from Hannah's point of view, how ignorant we can be. So I knew there was a lot I didn't know. I was also surprised in how many things I knew for sure that later on I was proven weren't accurate. And all the other things that I wasn't sure about at all, that later on I was proven to be accurate. And I could tell you stories about that if we have time in our Q&A here. But that was impressive to me. So I watch for studies that kind of change my mind and give me something new to think about. So this is a really interesting study looking at the impact of social media on mortality. And it's a pretty good sized study, a prospective study with 10,000 participants. So this probably is going to give you a stat sig on something, probably. They looked at these folks for 5 years, and here's what it turned out. If you have a negative profile on social media, that is a predictor of mortality with a hazard ratio of 1.5. It's about 50% more likely to die. Well, wow. You know, when a person came into my office and I was kind of assessing their risk and kind of extending their warranty after I did this history and physical, I would say, you know, let's talk about your hypertension, your blood pressure, your cholesterol, your sugar, all those things. I never say, hey, take out your phone, let me look at that social media profile. Oh, my word. You're way more likely to die. So I mean, this is literally more important in terms of that hazard ratio than obesity, diabetes, or hypertension. And it's right up there with smoking, and you can see the cancer, about the same as cancer. If you have cancer today, over the next 5 years, you're 60% more likely to die. If you have a negative profile on your phone today, in a year, you're 50% more likely to die. That is pretty impressive data. I like data like this. Now, even if it's wrong, it's fun. And hopefully somebody can reproduce this study someday. But that's the kind of data that as you're out there looking for things to approve, if you're looking at things, just get people out of how could we find something totally new and totally better and something that really will change. This is the kind of data set that I think meets the criteria that we talked about early on. Coming back to Daniel for the last time, we're often confident even when we're wrong. You know, of course, that's never happened to you. It's probably only happened to me, but we see this in healthcare a lot. An objective observer is much more likely to detect their errors than we are. And one of the things that Daniel Kahneman always preaches is, I will spot every flaw in your reasoning, and you can't. And you will spot every flaw in my reasoning, and I can't. And so a community like this is very helpful. Search out the people that disagree with you. They probably have something important to say. We tend to search out the people that agree with us. We tend to overemphasize the value of the things we're interested in. And as a researcher, he says this, I didn't say this, it's pretty amazing. Researchers have to be really optimistic people because they live their lives not getting very frustrated by all the things they didn't prove and really excited by the few things they did. Well, that's a pretty interesting commentary on research. And I'm glad our researchers are optimistic because they continue to give us data that is all kinds of fun. So I come back to my data wish list and just ask, please, every day, give us this kind of data. We will use it, and we'll use it to help save lives. So that's my presentation. We have time for a little commentary. So does anything come, I shared with one of my studies, that's one of my favorite data pieces. Anybody say, boy, I just love this data? I could give you a list of 3 or 4 that just really excite me, that I really love. But, yep. Okay. Any comments or questions? Do we have ways of taking anything from online or no?
And in fact, did we turn this off? Okay, do we need this microphone for Zoom? For questions?
You may need it for online.
For online. Yeah. Okay, well, I will bring around the microphone if you put your hand up, but I'm going to be naughty and take the advantage of having the microphone
please
first.
Do that.
First of all, this was fabulous. We're talking about where data makes a difference. You have just done it in front of our eyes. That's fabulous, thank you. And I shouldn't mention this, but your brother was my family doctor when I was a PhD student here. So seeing his picture up there, I get emotional, as you probably did.
So do I.
That was absolutely fabulous. What I would like to do, though, the one slide you skipped over was the mortality rates of those that were vaccinated. Do you remember that slide?
Yeah.
Are you able to whip
Yeah,
that
I
up and
can,
look?
I can back up, I think.
Because we looked at the infection rates for those that were vaccinated,
Yeah,
but you
the mortality
saved time
rate,
by
we
skipping
jumped
over
over
the
very
one that was
quickly.
about mortality.
It is this one. Is that the one?
That's the one. And while that's talking, while he's talking about, anybody with a question, just put your hand up.
How did you define a negative social media presence?
How do you define it?
Yeah, how'd you
How
find
did
negative?
they define it? You know, it was very broad. They just said, is this mostly ugly stuff?
Okay.
Or is this mostly, like really good stuff?
So
Are they
kind of a
repeating-
pessimism versus optimism?
Yeah, it is kind of. And some of it may be linked. They didn't unpack that, but I wonder how much that's kind of personality.
Yeah.
But you've seen these hateful kind of, those are
Yeah,
the folks
I defriend them.
that are dying.
Yeah.
And in fact, yeah, when your attitude can kill you,
Yeah.
we ought to pay attention to attitude.
Yeah.
Yeah.
I do, but I don't want to take this. Dr. Hamel, I enjoyed that very thoroughly, but one of the questions that I'm wondering is you have all this great data, and yet you have people that are data skeptics. And so, I mean, here we are in Berrien Springs with Andrews University, but
Sure.
you have a church entity not far down the road that has anti-vaccines,
Yeah.
and here you
Yeah.
showed all that
Yeah.
data. And what do you do with people that are just willing or unwilling to accept the data
Yeah.
that they disagree with? You talked about confirmation bias, but how can we be forces that help to examine this
It's
in
a
constructive
wonderful,
ways?
it's a wonderful question, and I could spend an hour on this question. It's a wonderful question. I would just say, we have learned, from a spiritual sense, we can't save every soul. We just can't. We can't change every mind. We've learned in politics that we're going to see things very differently. And in fact, there's now AI that can predict your political viewpoint way better than a coin toss from a picture of your face. Go figure that out. We're different. And so, I look at those things and I have conversations. I labored with people that decided not to get vaccines that died. That could have been prevented, I believe. And you should do the best job you can. And I would just say, the first thing you do is love like Jesus. These are not things we fight about. These things that we discuss lovingly as we know how. The second thing is that, and you saw this within the descriptions about how often we publish data that's wrong, is I can find data to prove just about any point. Now, it may be interpreted wrong. It may be they had 500 things they looked at to prove one point, and that is not an appropriate way of doing it. They may have loose statistical criteria. So, a lot of times they're looking at real data, but they're looking at not the whole data set. There are people that look at one scriptural text and can't see anything else. And, it's a great point. I do the best job I can. I do it as respectfully as I know how, as lovingly as I know how, and sometimes you don't win.